Not muted. Good afternoon and welcome to the Independent Scientific Advocacy Group public meeting. This week we are focusing on young people, specifically children, and the effects of the pandemic on them, both in terms of the direct medical effects and of course the other disruptions, including there's educational disruptions, as we all know about. And this comes in the context of just this week, just yesterday, in fact, the Irish government having approved, upon the advice of NIAC and based on the European Medicines Agency safety guidance, have approved the distribution of the mRNA-based vaccines to 12 to 15-year-olds. So it's been extended, which I think is good news for a lot of us. So we have our panel, as usual, to discuss various aspects today. And so maybe just to start off, we can bring in that topic, and maybe Anthony Staines could just introduce generally, update us on the news of the rollout of the vaccination to the 12 to 15-year-old age group, the extension of the eligibility to that age group, and the context for this and what it means.
Well, what has happened is that up to now, pandemics has only been available for adults.
COVID.
The COVID-19 vaccine has only been available for adults. Over the last year, a series of trials. Can you hear me? Yeah.
Yep.
Over the last year, a series of trials have taken place looking at these vaccines in younger children, so in adolescents aged between 12 and 18. And these trials have shown two things. They've shown that the side effect profile of the vaccine is acceptable, and they've shown the vaccine is very effective. This has been taken in conjunction with a series of analyses of vaccines given to older people across the United States. And the European Medicines Agency approved the use of these vaccines for adolescents in the last few months. NIAC has, in the last few days, made a recommendation to our government that the vaccine should be rolled out to that age group as well. And there's now very substantial experience in the United States where a very large number of people aged between 12 and 18 have received these vaccines with a very low rate of side effects. Those side effects are well known and well described, and there's been an extensive program of safety investigation of this vaccine. And the judgment has been made, and I think absolutely correctly, that these minor side effects are worth the price, because we know that COVID-19 itself causes serious illness in a proportion of adolescents and can lead to long-term injury in a proportion of adolescents. And the vaccination almost certainly prevents most of this. So for all of these reasons, looking at all the evidence that's available, the COVID-19 vaccine has been rolled out to that age group. We're going to continue monitoring the safety of these vaccines for the foreseeable future. But we have robust procedures in place to identify side effects, to identify risks, to identify groups who may be at particular risk, or people who may require particular care and attention giving the vaccine. So all in all, it's a very positive day, because if we want to control this virus in our population, we really are going to have to vaccinate a large majority of the whole population, and not just, as we have at the moment, vaccinated a large majority of adults. So we will be extending this vaccination to adolescents, and I anticipate we'll be extending it to primary school children when the evidence supports that decision. And that evidence is being collected as I speak to you. And we should have the evidence one way or another within the next 2 months or so for younger children.
Yeah, and I think it's very important, Jess, that it has been an evidence-based decision-making process. And as Karina Butler, the chair of NIAC, was discussing on the radio earlier today, as herself as a paediatrician, she was doing it directly with the interests of welfare of the children in mind. But I jumped a bit ahead. I made a bit of a mistake because I should have gone first to my colleague Philip Hovell for the situation update and the facts and figures. Apologies, Philip, and we'll get back to the discussion and everything else. But if you could do that, thank you.
Absolutely, no problem, Aoife, no problem at all. So welcome. This is the situation update, and I haven't been on one of those webinars in a while, but I'm meeting still with James Merrick and Paul Dempsey and others the evening before to take a look at the latest figures. So this situation update is really meant to provide some insight into those figures so that, as Aoife said, that we can form evidence-based discussion and hopefully decision-making as well. So let's go. So Ben, if you can give me the first plot, please. Excellent, thank you. So this is the slide that James Merrick, my colleague, just showed 2 weeks ago. That was the data that we had available at the time. So Ben, if you could go to the next slide, please. Thank you. So in here, that's the daily averages of confirmed cases, and we break this down for different age groups. So in order to compare those, we scale them to 100,000, so that the numbers become comparable across the age groups. So the big, thick black line, that's the overall average. And what I want to show you here is if you take a look at the y-scales, so the figure, the numbers there goes from 0 to 50. Let's say for the orange line, the age group between 20 and 29, that was 2 weeks ago around 45. So if you can get the next slide, please. So if you go to what it looks today, you see the scale has changed quite a bit. So we are at about the level for that age group 20-29 above 120. So there was quite an increase over the last 2 weeks. So it more than doubled in that week, and this is also true for all of the other plots there. So seemingly there seems to be a decline, a decrease over the last week. So in particular since July 1st. So and I would like to just give some idea what might be behind this. And this holds, as we will see on the next slide, Ben, please. You'll see that this holds in all of England. But if you think of Northern Ireland there, then the trend is not that dominant here. But in England, suddenly after July 21st, the numbers went down. So we had a closer look into this, and it's on the next slide, Ben, where we just pulled some cities really all across the place. You can see the different curves from Manchester, Liverpool, Brighton, UK in general, and so on. So you see that all of those suddenly had a decrease after July 1st, so Monday last week. And the reasons, they are not entirely clear. So there's been quite some debate why that is. So most likely, we feel that this could be a lack of testing of close contacts. So the initial positively tested person, there will not be immediate follow-ups for all of those that might be in contact there. So you will miss a lot of the secondary contacts that might test positive. There could also be reporting issues or kind of a delay in reporting because it's not so easy to get hold of those secondary contacts there. So in any case, we'll try to monitor the situation and get some clarity and further insight over the next couple of weeks. So if we go back to Northern Ireland, please. The next slide. This is the same data, but now we present this here in logarithmic scale. So it's the same curves, but they are scaled differently. You can see it on the y-axis, on the vertical axis, that the steps don't go linearly. So not 1, 2, 3, 4, 5, but they go in orders of magnitude. So they go from 0.1 to 1 to 10 to 100. And in this depiction here, it's easier to trace and to identify exponential growth, which would mean that the numbers today determine the increase tomorrow. And if it's a straight line, as we see it most of the period here, then it's an exponential growth, which is troublesome because if you think from one decade to the next, so from 10 to 100, in the orange curve, for example, it took 3 weeks, which means for the next 3 weeks, there will be another order of magnitude, and you would go from 100 to 1,000. And that's the dangerous aspect here. We'll see that all curves go in parallel, so they have roughly the same rate of increase, except for the bottom ones, which is the older population, so the 60 to 79 in red, and then in this brownish color, the over 80s, which seem to have a much a steeper slope than the rest. Right, if we can go to the Republic of Ireland then and compare those numbers. And let me start by plotting these, again, on a logarithmic scale, because they can see the heights much better from the start of the pandemic. And I marked the peaks of the first wave, where the peak was on April 16, the second wave, where the peak was on October 20th, and the third one, January 10. And where we are all the way to the right here, that's on the level of the peak of the first and second wave. Now, at that time, the peak was reached after around 10 days to 2 weeks after they introduced the lockdown. And then it took another 1 to 2 months to get the numbers down again. So at the moment, you're not thinking about introducing back lockdowns in Ireland at the moment. But if we were to do so, we would still expect a growth over the next week, at least, before it will eventually, the curve will turn around and then ultimately, hopefully, become smaller and smaller and decay here. All right, if we can go to the next slide, please. There we have the breakdown for Ireland as well, for the Republic of Ireland in terms of age groups. And here the scale, you see again, it goes up to 40. It's much smaller, much lower than in Northern Ireland, luckily. And we'll also, but you can also see that the younger age groups in green and in blue. So this would be the underage between 13 and 18, and then in green this would be 19 to 24. So that age band. So they are, there's a stronger, higher numbers there, so it's a stronger concentration in those younger age groups. What you can also see is that the numbers increase at a higher rate than they would compared to the average. If you can go to the next slide, please, Ben. Now, in recent times, for 2 weeks, we had this around 40, and now the latest figures are again up to 100. So the curve that we had before were included here, but on the very, very lower end of things. So the numbers have increased since about 2 weeks. And when we look at how the rate increased, how the rate changed, then we can also see something interesting. If we would replot this in log scale, which is on the next slide then. So here in black, again, it's the thick line in black would be the overall average of the whole population. And you can see, if you follow those curves from the bottom here, it's the older population, so above 80, and the next age group there. You can see that while it used to level for a couple of weeks there, so now it's increasing as well. And then the orange curve right on top of that, so the third curve from the bottom, that's the very young ones. So while we saw that there was not a big increase over the last couple of weeks, most recently, even the very young population started to increase. And then here we can see much better that the top two curves, the green one and the blue one, so 13 to 18 and 19 to 24, that they are increasing at a much higher rate than the overall national average. So this is the advantage if you plot those in logarithmic scales. So the highest rates at the moment in the very old age group and in the younger ones. Now, let me just finish with 2 more comments here. One is about the vaccination, because it has been mentioned already. That's the latest figures here. And if you see that this is the percentage of adult population vaccinated, which, if you think of the fully vaccinated one, it's close to 70%. But now I should emphasize that this is the adult population, and today we're talking about schools in particular. So if you scale this to the whole population, then there is, well, a good quarter of the whole population missing. So that optimistic figure of 70 should really be seen really that we are reaching 50% of the population at the moment. I also put the numbers from 2 weeks ago and from 4 weeks ago. We'll see that there's a steady increase. But the advice here would be, again, just follow that upward trajectory, get vaccinated as soon as possible. And on the end, don't lose your level of vigilance. So to observe public health guidelines, and anything that you practiced over the last couple of months will still be important, because we should all remember that no vaccine is perfect. And if we've seen what we have seen in the UK, the more people get vaccinated, the less they get tested. Also, they can still spread the disease and even become asymptomatic sick. Now, finally, maybe on the European picture, because it also nicely connects what we saw over the last couple of weeks, where I remember that Paul mentioned last week and James 2 weeks ago that Ireland in green, of course, was almost on the average of the European Union, which would be the orange curve. Well, this was two weeks ago, and now we would be above the average of the European Union. So the numbers increase much higher than they would in Europe. What's also interesting here, and I plot the Netherlands in pink, in purple magenta here, you see that those numbers go down. But again, the peak that we saw in the Netherlands, that was not immediately after they introduced restriction. That was 2 weeks after they did so. And we see that's yet another 2 weeks since there's a considerable decrease. I also added Spain, which is on the rise at the moment. And if you think of holiday period, so people returning from holiday places, then we should brace ourselves for impact there as well. Final comment is on Germany. Down there. So there's currently a big discussion whether or not they want to introduce mandatory testing for anybody returning, independent of the vaccination status, whether they had been sick before or not. And they are talking about introducing this weekend already. So let's see how that discussion unfolds. So that's it for the situation update. Back to you, Eva.
Thanks, Philip. I mean, they have definitely in Germany a position worth protecting. They're quite striking on that graph, how low their case numbers are compared to the European average. And we're above European average, as you mentioned, along with the Netherlands and Spain. And of course, that average includes the Netherlands and Spain, which will be dragging the average up compared to, there's a lot of countries you would think that are better off than us in Europe at the moment. Yet we are talking about opening things up. And of course, that drop in the Netherlands is very striking. And this is after they had that huge peak, they had to reintroduce several control measures. They had accelerated a bit too quickly. Isn't that the decision that was made there when they opened? It was like indoor hospitality and nightclubs and things like this that they had opened, and it gave rise to that huge increase. But just Philip, if I could ask you one thing. You know, I'm sorry if you said this. I was trying to deal with some technical behind the scenes issues and I missed some of what you said, but it's rather interesting what's happening in England at the moment. And I mean, the UK, but not it's not Northern Ireland, but the rest of the UK, Great Britain, with the case numbers coming down. Is there any explanation for that, or is this just something we have to wait and see? I mean, it looks very good to see those numbers coming down.
It's always good to see numbers coming down, of course, and we don't know whether this is a real trend or whether this is just some, say, reporting issue or some systematic event. So that we see this all over the place, that gives us the idea that this might not be that this might be something artificial. So not something real, because the curves, they were not in sync for many of those places before, and suddenly all over the place they go down. So we think that most likely that's because of not, say, mandatory testing of secondary cases, or that there's a delay in testing secondary cases. So as far as I understand at the moment, you're only being tested if you have symptoms, but even asymptomatically, you can spread the virus nonetheless. So I fear that this has to do with the change of policy, so that contact tracing has been, well, not paused, but at least hindered since Monday last week. So that this is something that the hidden figures will be much higher than what we see at the moment in the data.
And I understand there's some difficulty in counting reinfections, because it's hard to know if it's a reinfection versus a lingering infection. But maybe that doesn't contribute very much to those numbers, I suppose, at this point. Yeah. I think I'd like to bring in...
Also, there's also an advantage if you plot those in logarithmic scale, because those drop, although it's big and if you see it beyond the peak, but they had levels off, and you can see the general trend if you take it on this logarithmic plot. We can see that this general trend is still be pointing upwards.
Yeah. I think Jerry wanted to come in here as well, I think, because you had some point on the situation in the Netherlands too.
I'd appreciate your views on this, Philip. You know, one thing, if I was to interpret the Netherlands trajectory at face value, I'd at least find it comforting for many people who have doubts about, whether Delta is containable. I think the good news is it looks like, as several other countries have shown, that it is containable. But I'd like your views based on how much, I guess, how much trust you place in those trends?
Yeah. So the overall trend, I think you can get a good picture of where things might go if you don't change anything. Right? So then Northern Ireland, Northern Ireland Republic, the same. If we continue as we were at the moment, so then we would have a tenfold increase within 3 weeks. So at the moment, it's doubling every 10 to 12 days. So by say come end of August, we would have another kind of record numbers in terms of the overall case numbers reported ever, including the third wave in January. So that's quite a risky scenario, because then getting down from that figure, it will take probably, if not to Christmas, but very close to that one. So that's what the general trends could tell us. Since you mentioned Netherlands again, what I found striking there is that they kind of reverted their decision for hospitality and indoor opening. Even outdoor gatherings were suddenly abandoned and prohibited within 1 or 2 days notice. And still it took like 10 days until those measures saw an impact. So it's not that you switch something today and you will see the impact tomorrow. Well, there's at least a lag of like a week to 10 days until things might turn around.
But they did have an impact, so we do have options, and we're not trapped in a sort of inevitably upward trajectory.
No, they do have an impact, certainly, but it takes some courage to implement those, right? And to say that, no, we wanted to open, but no, for the sake of and the safety of everybody, we need to revert that decision. And then people should kind of hopefully see the impact and the prudence of that decision in a week's time.
Yeah, very good choice of words, Philip. It takes courage, and it has. We've seen that over the last year and a half. It takes courage to make difficult decisions in this whole pandemic. So we did things slightly out of sync. That's my fault. So we already heard. So that situation update has been really informative. Thank you, Philip. And we heard from Anthony Staines before that, who gave a quick recap of what has just happened in Ireland in terms of the vaccination, the COVID vaccinations being rolled out to 12 to 15-year-olds. At least they've been now considered eligible, and this will start happening soon. And as we say, this is not only for the benefit of others. So there is a general benefit to the whole population with increasing vaccination numbers, but it's also in the interests of young people to get vaccinated to protect themselves. It's striking that Philip just said that we could have record case numbers by the end of August, which happens to be back to school time, and that these numbers would exceed anything we've seen previously, including in January. And those numbers would presumably be concentrated more in the unvaccinated population, our young people. Then they would be presumably intended to go back to school. And so this becomes very critical for this group, which is the context for our discussion today. And I think, so I'd like to bring in Andrew Kunzman now, because an important part of the context for why we feel it is correct to offer the choice of vaccination to 12 to 15-year-olds where the vaccines have been tested and found to be similarly safe as for older populations. And it's because although we know the risk of death and very serious disease is thankfully much lower, there's also long COVID, which we have learnt about over the last year, and we are still learning, but there is good evidence at this point. And we do have some good studies. And I just thought, Andrew, you could tell us a bit about what do we know about long COVID in children and in general, and what can we say at this point, and where do we still need to be cautious as we are learning?
Yeah, thanks, Aoife. So we've been collecting evidence on this throughout the pandemic. At the start of the pandemic in particular, the evidence was very limited, and as an epidemiologist, I often had doubts about the quality of the evidence, but it all seemed to be pointing in the same direction, that as a proportion of confirmed cases, which would be slightly more severe, the prevalence was fairly high, and certainly not a risk I would take with any kids that I know, and would be uncomfortably high. I think we all knew that actually the true prevalence, once you accounted for asymptomatic infections and cases that weren't detected, that it would be lower than that. And some of us had hoped that it would be much, much lower than that. Unfortunately, the evidence, the stronger evidence that is available, does suggest that there is still between about 5 and 10% of children that still have symptoms about 12 weeks after their initial infection. And this based on the ONS study. Some people will say, oh, but kids are tired, it's lockdown, what's the problem? It could just be something else. But the good thing about this study was that they actually recruited controls who tested negative at the same time and then asked them about their symptomology. And in fact, the symptoms were very, very low in children who didn't test positive for COVID at the time. So that suggests that we probably can rule out that this is purely background noise. Now, the ONS study isn't perfect, and I would love to come back and say, actually, there's about 5 or 10 good studies that all point in the same direction. Unfortunately, there's about 100 studies, and I'd say 99 of them aren't really that informative. We had some fairly optimistic news recently suggesting that actually it was fairly low, around 2% of additional kids get long COVID. Unfortunately, the study didn't really use an appropriate method for that. It assessed serology, so whether some kids had antibodies to COVID-19, and found that those with antibodies had about a 4% prevalence, whereas those without antibodies had about a 2% prevalence, which sounds a bit more reassuring compared to the 5 to 10% seen in other studies. But unfortunately, that was only based on about 4 children, and that's really not enough to give any indication. And the time period they used was after the point when they tested positive for antibodies, not after the point when they tested positive for infection. So that means we don't know when they were infected. They could have been infected 6 months before. This was in October, so any children that were infected in the whole first wave would have been missed by this study design. So this is actually capturing potentially how many kids have long COVID 6 months plus 12 weeks after their initial infection, potentially. And if it's at 2% extra with wide confidence intervals that cover up to 9% because it was such a small study, that becomes a bit less of a reassuring picture. And I think that that's one of the things that we need to consider is, what do we do when the evidence is weak, but the best evidence is pointing that actually a significant number of children still have symptoms? And for me, it's take the precaution. Don't take a risk with children's health. I mean, with anything else, parents wouldn't take the same level of risk that they would with their own health for their own children. And I think that's the precautionary principle that we have to take, is err on the side of caution and do as much as we can to make schools safe and prepare now, because it's only a few weeks away. We have no excuse not to be doing everything we can in the background to make sure that when schools go back, that children are safe and their education won't be disrupted by being contact traced or tested. Or the more we do to make it safe, the less of an impact it will have on their education.
Yeah, and they've had an extraordinary amount of disruption. I think it would be really so unfair if there was another year of disruption for their education. But just to bring you back, so the ONS, that's the Office of National Statistics, the UK agency. And so their study, as you describe it, is the most powerful one in terms of being actually able to learn from it, because they designed the study well. They had groups that they could compare. So they had children who they knew had not had COVID, had tested negative, children who had tested positive. So they were able to directly compare those. And of course, all else was equal. All of these children were living through all the other negative parts of the pandemic that we know about, and the isolation and the disruption and all those. And then the symptoms were seen in the test positive group. Could you give us a bit of a flavour for the kind of symptoms that people are seeing with long COVID in children?
So this will range from fatigue, coughs, so that some of them will be mild. And I think that's one of the things that the debate you'll often see scientists debate quite vigorously over long COVID and what it means. And they accuse people of scaremongering for saying the 5 to 10% figure, which is not to create fear in any parent. I wouldn't want any parent to leave this and say, right, okay, that's worrying me. It's not to create that, it's to avoid it happening in the first place. And some of these symptoms will be mild, and some of them will be resolved shortly after that 12-week period, hopefully. But it's just that we don't know how severe they are, and some are reporting that these are having quite a big impact on that child's life. And that will affect their education. Fatigue can be mild. I think we're all a bit tired at the minute, but that's not the level of fatigue that they're reporting. They're reporting that this is having an impact on their life very often. And I think that's the important thing, is getting studies that will point at that severity of fatigue, headaches, brain fog. If a child isn't able to concentrate, then they're not going to learn quite as effectively as they would. And that will impact them for quite a long period of time. So it's about avoiding that happen when we don't know exactly how many will get this.
Yeah.
Avoid it until we know more.
And we have multiple tools at our disposal, of course, to avoid this and to protect young people. So vaccination is one of the tools for 12 plus, but for all children and for all schools, we know that it's really vitally important that we have good ventilation, good air quality through ventilation. And if ventilation isn't possible, then there's HEPA filters and the like, and also high quality masks. So maybe we need to get a clearer message out there that, a bit of old T-shirt pulled up over your nose isn't going to do much, but a proper mask that will allow the person to breathe comfortably and at the same time will catch the particles and protect them and the people around them. So Gabriel Scally, I was hoping I could bring in you here now as well, because we are aware here, because we follow the UK news, that there was a different approach to vaccinating 12 to 15-year-olds that was taken in the UK. Could you maybe tell us a bit about that and give us your view on that?
Yes, it is very interesting and a matter of great controversy. The UK vaccination program only applies to people 18 and older, so that whole group between 12 and 17 are not being offered vaccines. And all the government have said is that they will offer some to those particularly vulnerable within that age group. And it's very difficult to understand. And let me separate the two functions that are in operation here. One is the safety bodies, the bodies that are there to assure the safety of the vaccines, a bit like the European Medicines Association, EMA agency, the European Medicines Agency across the EU. The MHRA is the initials of the UK body, and that body is the body that produces the approval for use, and it is takes into account the advice of the Human Medicines Commission, an independent commission that looks at these issues of all human medicines, including these vaccines. And the Human Medicines Commission and the MHRA have now approved the Pfizer vaccine for 12 to 18-year-olds. It was previously approved, I think, just for 16 and 17-year-olds, not for the lot. And then that advice went to the government's advisory body, the JCVI, the Joint Committee on Vaccination and Immunisation, which isn't a safety, it's not a safety watchdog body. It's really more of a policy body that advises government on what vaccine policy they should introduce what the spacing of vaccines might be, what ones would be used in what groups, etc., what diseases would be vaccinated against, and produces the schedule of vaccination, and that is operated by the health service. And that JCVI, having acted really, really amazingly quickly, like within 24 hours or something like that, or 48 hours, of the initial approval of the vaccines in the UK, took weeks and weeks and weeks to come up with a recommendation about children and young people. And it was played out quite interestingly in the media as well, with it being very clear that there were split views, that there were some members of that committee, the JCVI and its COVID-19 subcommittee, who were in favour of vaccinating, and others who were much more reticent, and amazingly included at least one person who didn't believe that long COVID existed, which is quite bizarre that someone like that should be on one of those committees. And they eventually, it was rather a finding of there was no agreement that it should proceed except in the vulnerable groups. And that leaves the UK in a very difficult position, because that group of 17 and under across the UK make up 21% of the population. And that's just a huge chunk of the population when you have a virus as infectious as the Delta variant is. And to get to the level where we get some element of population immunity coming into play, we need way beyond that. And it seems very odd. Here we have a vaccine approved on safety grounds, and the government isn't willing to use it to help protect its young people. So it's a most unusual situation, and it results in things happening. Well, there has been a general concern that the vaccine program is slowing down, and that isn't surprising to any of us who've run vaccination programs. It was a very well organized effort with a great deal of organization put in by the NHS. It was really based on the NHS. But most of us who have done this before know that you can get up to 70-80% quite easily in a vaccination program for a target population. But getting it up into the late 80s and into the 90s across the population is really, really tough. And it requires a lot of local action, and it requires local primary care being involved in local public health teams. And I think one of the problems is that the healthcare system is just so busy coping with not just COVID-19 acute illness, but also with the backlog of care needs arising from the restrictions and restrictions on what could be done, but also the tremendous tiredness there is amongst the staff and so on. So the vaccination program is tailing off, and that's allowed, for example, on the island of Ireland, that the Republic of Ireland has now more vaccines per head of population in its population in the Republic than there is in the north of Ireland, despite the huge lead that Northern Ireland had in terms of earlier approval. The Republic has caught up and overtaken, and will go further ahead, of course, because of the very welcome decision to vaccinate young people. So again, the UK has taken quite an exceptional position, particularly when there are 10 million young people who have been vaccinated in the US. 10 million, it's amazing. And we know what the health profile is. And it's well publicized that there is a significant side effect in young males from one of the vaccines of pericarditis, but that is a treatable side effect. And also data emerging to show that you're 6 times more likely to get that side effect, to get that condition, the pericarditis condition, if you catch COVID-19 as a young male compared to having the vaccine. So it's a kind of no-brainer that the choice has to be pro-vaccination, but not in the UK for some reason. So again, it's one of those inexplicable Whitehall and Westminster decisions. And it will be interesting to see whether any of the devolved administrations break away from that and try and do something differently.
Thanks, Gabriel. So it is very interesting that we basically see different interpretations maybe, or different emphasis on different parts of the evidence. And I think I bring Jerry Killeen in here because it is, when we talk about the evidence for these things, like, so the evidence for long COVID, as Gabriel just mentioned, apparently one member of the JCVI, if I got the acronym correct, it did not take long COVID, did not believe in long COVID, did not take it seriously, whereas others perhaps were not of the same view. And as Andrew mentioned, there are various studies, but the one that he placed most faith in, the most robust one, actually was indicating that long COVID, it's got robust evidence that long COVID is real and it's serious in young people. So, Jerry, what do you think about this in terms of the evidence and what we can learn from different types of evidence?
Thanks, Aoife, and thanks, Gabriel, and thanks, Andrew. I spent the last couple of days going through the long COVID literature, literature and evidence base, really looking at it as a father of two young teenagers, looking at how we manage our household risk, the remaining risk that we have left in the remainder of the pandemic. But I also look at it as a father who has managed quite considerable infectious disease risk for both their kids. And also I've worked specifically on global policies in relation to subtle debilitation arising from parasitic disease. Okay. And the literature, the evidence base for long COVID has a really familiar look to it. It's got lots of studies that are imperfect or have small numbers, so they're uncertain, but there's no specific reason to doubt them. Now, there are also studies that are, do have obvious biases, and there are reasons why you might not give them credibility. But then there are like some really worrying ones in here that they're not perfect, but there's nothing obviously wrong with them. And they look kind of like the studies that we all had on kind of subtle debilitation of kids in particular in malaria affected countries, and which has such a long-term effect that you can actually measure the impact on national GDP. Okay. Now, the experience we went through with that policy process is that all those, pretty clear but not 100% convincing studies all pointed in the same direction. It was only when we got into really big studies that you started to see all the inconsistencies just evaporate out of the data, all the graphs, become clearer, the trends are consistent, everything triangulates off each other, so different measures, different ways of looking at the data, they all produce a consistent picture. And that's what I see in this ONS study, which had 20,000 COVID cases and a matching set of controls. It's really convincing. As a parent with an expert background, I think it's pretty much on the money. I think that long COVID rates in kids are about 7%. Even if I look at the lower range of the 95% confidence interval, so in other words, we're 95% sure it's not less than. That number is 5%. So we're 95% sure that it's not less than 5% in kids. These are kids from the UK, right next door, no big cultural differences or any other factors. For me, 5%, it's too high for my kids. It's too high for all our kids. And if we look at our current incidence rates and we look at what proportion of those are kids, we're looking at about 24 kids a day who are going to be debilitated in a way that will last for at least 3 months. And for some of them, it might mean a lot longer. And for me, that's an unacceptable risk. Anybody who knows me pre-pandemic times will know that I'm very fond of pubs and pints. But, given the choice, let's Schools are more important. Our kids are more important. We can all wait for a restaurant meal. We can all wait for a pint. It won't kill us. There's never been a shortage of either in this country, and we just need to make clear decisions and courageous decisions. And again, I would applaud all the people who are prepared to change their minds over the last week or so, including some colleagues at NEFIT who I might have been a bit critical of, but I'll buy them a pint when we can all do so safely. Thanks, Aoife.
Thanks, Jerry. I look forward to the party too. But I like you. I also feel that the risk of long COVID is unacceptable. So, same that I I'm looking forward to vaccination for members of my family. But I'd like to bring in Anthony Staines here, because I think people are right to be cautious in thinking about vaccine safety, and some people may be aware of an unfortunate and a bad episode in terms of vaccines, which was with the pandemics. And maybe you could talk about that briefly, Anthony, and just say, what happened there and what do we learn from that? And some people might be asking, how can we trust agencies to make decisions for us, given what happened there?
I mean, very briefly, pandemics was a vaccine for influenza, and it was a vaccine that was produced the particular type of vaccine was produced by a number of different companies in a number of different plants, and one vaccine from one plant caused quite significant problems. And there were a small number of cases of a condition called narcolepsy, which is a serious neurological condition that affected largely children. And the frustrating thing about pandemics, about the whole story, is the safety mechanisms for detecting the risk worked pretty well. It became clear within a couple of months of the start of the use of pandemics that this particular production stream of vaccine was associated with relatively high risks of inflammatory responses. What happened was that no proper action was taken, and the vaccine continued to be used. It was stopped, but it wasn't stopped in time. It should have been stopped earlier. And that has, I think, taught everyone in this area in vaccine safety, what's sometimes called pharmacoepidemiology, a serious lesson that we need to monitor these things in real time. And what we've done with COVID is we've done that. So we detected the clotting problems very, very quickly with AstraZeneca. And my clinical colleagues were able to come up with good advice on how to treat what is a serious but rare complication. It then became clear that similar clotting problems arose with another of the vaccines, though not with the RNA-based vaccines, and they could be managed in the same way, but they were less frequent. With the RNA vaccines, because we were doing the safety monitoring, it became clear that they caused myocarditis, which sounds very dramatic. It's an inflammation of the heart muscle, but it's not uncommon as part of other viral illnesses. It's not uncommon as part of COVID. And although it does occur, in most cases, it's not that serious. So the majority of kids who get this are back at school within a couple of weeks. So it's a rare side effect. It's been recognized. My clinical colleagues have been given specific advice on how to manage it, how to pick it up, what to do about it, what action to take. And that's how we do vaccine safety. Everything we do has side effects. Everything we eat, everything we drink, everything we breathe has side effects. And we spend a lot of time as a species managing those side effects, managing those risks. For vaccines, we have a very elaborate and now, I think, well-working safety system, which has proven itself because it was able to detect these rare events. These are events that 20 years ago, we would never have known about them. We might only have found out about them in retrospective studies 5 years after the vaccine campaign. Now we're finding out about them in real time. So if there are side effects for a given vaccine, and there are side effects for most vaccines, we find them. And we can then make an informed decision. Here's the vaccine. Here are the complications of the vaccine. Here's the virus. Here's the complications of the virus. And weigh them up and make a recommendation on what's best. And the recommendation from the experts in this area, and I would agree with it, is that COVID-19 itself causes a very wide range of inflammatory conditions. I think Jerry's figure of around 7% of children having long COVID is probably accurate. I think the literature is all pointing that way. What we're finding is that as we get better and better studies, the evidence for long COVID gets stronger and stronger. If it was nonsense, the evidence for long COVID would get weaker and weaker and weaker as we did better studies. So these children are at significant risk of certainly potentially life-altering illness. And if you're a child and you're unwell for a year or two, which seems quite a likely outcome for long COVID, the impact of that actually runs through all of your life. So weighing up these, it's clear to me that the judgment should be that we vaccinate children against COVID. If my own children are now grown up, if I had children of the relevant ages, I would absolutely agree with Jerry that vaccination is the way to go.
Butler was speaking earlier today on Today with Claire Byrne on the radio, and she is the chair of NIAC, and she's also a paediatrician. And she made the point that it was their view that this vaccination is important for protecting those children. So not only for what they do, it also helps protect the population, but that their primary interest was protecting the children. So there's questions about schools, and I think Tomas Ryan, I could bring you in to talk about this, because there's a question that's come in. So yesterday, the Department of Education said the public health advice that we had before is sufficient mitigation to deal with the next academic year. Not even though now we know we're dealing with Delta, which is more transmissible, and so maybe you could talk about this in the context of case numbers and the kind of appropriate mitigations. Is an optimistic opening the window and a bit of hand gel going to fly this time?
Right. Well, we know that statement is simply not true. First of all, the Delta variant is far more transmissible than the B117 variant that we were dealing with since Christmas. There's evidence to suggest that people can carry up to 1,000 times the viral load, and it's clear that it's easier to transmit this particular variant. More to the point, the measures that were in place previously were not sufficient for controlling transmission of SARS-CoV-2 in our schools. And this is becoming a very serious issue because we're approaching a stage where schools are likely to open, but with the kind of case numbers that we were seeing in and around the Christmas period. So when we opened schools last September, we were having on many days around that week less than 100 cases a day. And that was with the original wild type variant of SARS-CoV-2. Now we are seeing a situation where we may have thousands of cases a day as schools open. Obviously, no one can predict exactly what is going to happen over the next few months. We're hearing very optimistic projections, for want of a better term, from people such as the Tánaiste Leo Varadkar, who are hoping that we'll peak going into August, maybe around now, and then cases will decline as we go into September. However, all of NEFIT's modeling suggests that we will peak either in September or October. And the peak could well be at something like 3,000 to 5,000 cases a day or more of the Delta variant. Now, this is the kind of numbers that we were seeing coming into January. And of course, the reaction to that in January which was very different to our reaction in September, was to not open the schools for many months. And the reason for that, in the narrative that was dominant at the time, was because schools would contribute to transmission in the community. And of course they do. And this September and October, schools will also contribute to transmission in the community. But the difference is most of the community is vaccinated. However, none of the children are likely to be vaccinated at that time. It's very positive news that we are going to be vaccinating 12 to 15-year-olds. But based on any even casual assessment of the logistics behind this, suggests that we would not get to full coverage until November or the end of November. And then under 12s is an entirely different situation. So essentially, for most of the coming school term, the child population in Ireland will be unvaccinated, but potentially in a scenario where we have an extremely high number of cases in the community. And we're talking about Delta cases, which of course are highly transmissible. Now, this could result in a situation where we have an awful lot of long COVID caused in children, specifically by a period of months that is right in front of us. Now, closing schools is not something that we do lightly, and it's not something that we necessarily want to do, because it has huge costs on society, it has huge costs on mental health of children, it has huge educational costs, and of course there are issues then with domestic violence and other issues associated with children not having access to the educational system. But if we are going to open schools under these conditions, it's absolutely essential that we do everything that we can to mitigate against it. We're starting to see that the government are taking the airborne nature of SARS-CoV-2 seriously, and we're hearing that classrooms will have CO2 monitors, and that is a positive step. But a CO2 monitor does not ventilate a classroom. A CO2 monitor tells you something about the CO2 concentration of the classroom, and it's no use without clear guidelines about when you actually send that class home when you're not happy with the result in that environment. That must be clear and that must be observed. We also need very clear isolation guidelines for when a student tests positive. We need to be testing contacts of that student in the classroom much more rigorously than we've previously been doing. One of the reasons why schools have not been seen in the public as a major locus of COVID-19 transmission in Ireland is because we haven't been looking closely enough at the contact chains within schools. And we need to probably be doing some kind of a more thorough, in my opinion, sentinel testing of schools and classrooms across the country, even if it's without rapid antigen testing, so that we can get an idea of what the kind of occurrence is like. But I would really like to hear more from the public health experts and epidemiologists at this webinar now to get their opinion on that particular aspect of the situation. But the point is that this is a multidisciplinary problem. Vaccines alone are not going to solve the pandemic in Ireland. We're seeing this more and more. We need a vaccines plus approach. But as regards schools, vaccines are not even on the table yet. Schools are now going to be the sector of society that will be vaccine free for the coming months. And therefore, mitigation measures are going to be even more important there to protect the health and well-being of children. And it's my concern that the government is not currently taking this particular issue as seriously as they should be doing.
Thanks, Tomas. I think I'd like to bring in Gabriel Scally here as well, just on this same topic, because of course in the UK, their school holidays started later than ours. So you have seen what it's like to have schools open while Delta is spreading in the population. And there's also questions from the audience about, this is not a short-term problem. We might need to keep these mitigations in schools into the future. Do we need to be thinking more long-term about this? And as Tomas mentioned, in Ireland, at least, we're getting the CO2 monitors, but do we have good guidelines on how to respond to those and how to react to a high level? The levels that were suggested that might be acceptable, 1,500 parts per million, whereas other people will say 800 parts per million should be the threshold. And then open the windows, or what do you do? And so maybe there's a lot of things in there, Gabriel, but see how you get on. So like, what's happening in the UK, and what do you think about the mitigations that need to be in place?
Well, there's not a lot happening in schools in either of the two islands, really, I think. And I think that's really, really disappointing that we're not paying attention to the primary prevention of this disease. We're paying much more attention, rightly so, in the acute phase to illness, and we're paying a lot of attention to vaccination, but we're not really dealing with prevention. And there's nothing mysterious about this disease. It is an airborne disease. One of the things we need to do is catch up with the nature of it being airborne, because I think a lot of people are maybe stuck with some of the messages that were coming out at the very beginning of the pandemic, when it was all about droplet spread and coughs and sneezes, and it was about touch as well, and the cleaning and hand sanitizing and disinfecting of surfaces and so on was seen as important. Now we know that air is the single most important thing. And it's not so much that's a new discovery. Air has always been a major transmission vehicle for infectious diseases. And our schools, at one point, responded to that brilliantly. About 100 years ago, when in the post-Spanish flu era, and when we still had real problems with serious infectious diseases amongst children in particular, schools were completely changed in this island. It started in Belfast, a tremendous revolution of school architecture and building that was building healthy schools. And we moved away from that concept of if you make the environment healthy, then people will be healthy in that environment. And we need to rediscover some of that. In the more acute time we're in now, at the moment, we should, of course, be doing more. And that requires a program of, it has to be an organized program. It's not just good enough to say, oh, well, you have to open a few windows. Opening a few windows doesn't necessarily work. It might make a difference, but it's how you do it, when you do it, how wide they are, et cetera, et cetera. And we're really not taking this seriously. When you look at what, I'm being very impressed by New York City and the public schools in New York City. And if you view a child in school in New York, you can look up your schools on the website of the education department. You could look up your child's class. Every room in every school is numbered, and you are told what the number of the room is that your child is in, and you could look up the ventilation report on your child's class, whether it's got windows, whether they open, whether it's got an exhale, an expelling, or an inhaling fan, whether it's got an air conditioning system, what the state is of the filters on. All of that stuff is available for every child in their classroom. And they have a program of works. And one of the great things they did in New York, right at the beginning, they started recruiting school nurses, so that they are trying to get to the level of having a school nurse for every school to make sure that that school is healthy and the kids are looked after. I think that's fantastic. But their recommendations, for example, from the Center for Diseases Control in Atlanta, Georgia, which advises the US government, is the federal body, and it's one of the most powerful public health bodies in the world. It says very clearly in their school program, filter and or clean the air in your school or childcare program. Improve the air, a level of air filtration as much as possible. Make sure the filters are sized, installed, and replaced according to the instructions. Consider portable air cleaners that use high-efficiency particulate air filters, that's HEPA filters, to enhance air cleaning wherever possible. Consider using ultraviolet germicidal radiation in schools. Now, where is the guidance for that here in Britain or Ireland? We don't have it. Why do we not have a program for making our schools healthy? And it would pay dividends in the long term as well, because the transmission of diseases, infectious disease in school is a part of life and has been a part of life. And we would do so much better in the years to come if we set about now making our schools really fit for purpose for this modern era, for this COVID era, but plus, set us up for healthier schools in the future. I think it's a great program. The cost isn't huge. This is minuscule compared to the costs of healthcare resulting from things like the pandemic. And it's so worthwhile doing. And some of the great initiatives that I've seen being led by parents, where they're getting together to try to raise the money for air filters for their schools. Citizen science, where people are putting together, where the school authorities or education authorities aren't doing it, they're putting together their own checklist for all the rooms in schools, along with teachers and head teachers, and seeing what needs to be done. And that's the sort of mobilization of local communities. And they're great examples. You know, I still show the slide all the time of that wonderful school in Wicklow, where the parents in one weekend built an outdoor classroom for the kids. And I just think that's brilliant. And we need that sort of community engagement to make our schools healthy.
And it's really useful as well, because when you have clean air technologies or clean air approaches, engineering approaches, it works no matter the variant. In fact, it works no matter the airborne virus. You know, we don't need to keep catching up. But I think, you know, we've been told so much that schools are safe, and you know, we don't need to worry about schools. Jerry, I'd like to bring you in on this. You know, people keep saying, repeating it until they hope it becomes true. The schools are automatically safe just because.
Thanks, Aoife. Yeah, I think sometimes we try to be diplomatic, but sometimes we just got to stay it like it is. So I've gone back to some of my old go-to literature from pre-variant of concern times, from old Wuhan wild-type virus times, and I look at the best evidence on, big hitting evidence on the efficacy of different interventions around the world and the roles of children in transmission. Now, the funny thing about epidemiology, it's a very, it's a tricky business, and there are lots of things that we can't see directly, or we detect in a very small minority of cases. And one of those is cases in children, because the virus is far less virulent in children. So we only pick up a minority of those cases. And so for things like that, where we can only see the smallest tip of the iceberg, we need big studies that look at the impact of processes at the macro scale, like on entire communities, entire countries, or we look at their impacts on other people, where we can see the consequences much more easily. So, here I've got, so these are three of the best journals in the world. This is from Science Magazine, and it studies the trajectories of 41 countries, the impact of different non-pharmaceutical interventions upon them. The impact of closing schools there is in excess of 35% on the reproduction number. Nature, Human Behavior, the kind of journal I dream of being in. And this time, 226 countries. All their trajectories carefully documented, and all three school sectors, primary, secondary, third level, childcare, all of them, they contribute about a 20% increase to the reproduction number each in this one. And then we have in the British Medical Journal, a study of 9 million adults in households that either have or do not have children in them. And you see, a 20% increase in infection risk and hospitalization risk associated with sharing a house with school-age children. So if I was to believe what our schools team at the HSE are telling us and what our Department of Education are telling us, then I have to take all of this stuff and tear it up. This is the best science in the world, and this is wild type, pre-variant of concern COVID. This isn't alpha or delta. So either all of this is wrong, or schools are a huge hub for transmission and contribute in a major way. And I just don't believe that we have some magical Hibernian version of the virus that behaves differently from 226 other countries on the planet. So, we can't both be right. And I side with these folks. And I hope nobody on the NEFIT schools epidemiology team takes offense.
We have one more question, which I think we can just fit in before we wrap up for the day, and it's on the same topic. So this person is asking, if nothing changes with respect to school COVID mitigations and return in September takes place without anything else, no ventilation or clean air plan, what can parents expect to see in autumn with respect to infections and outbreaks? Maybe Philip, you might be able to hazard a guess on that. And is there enough evidence to make best type predictions on the impacts? And maybe could somebody paint a picture that parents can just visualize and anticipate a worst case scenario with educational disruption? I don't know, Philip, if you'd feel comfortable making I know, models are not predictions, but if nothing changes, what would we see with schools opening? And then maybe Anthony could answer about, just with educational disruption and, school closures and things like that. But Philip first.
Yeah, absolutely. So as you said, prediction always hard at this stage, and we can only say what the limitations of the models are, and based on those limitations, what the models tell us there. So first of all, if the trend that we see in the last couple of weeks continues, I don't think that we see the schools opening, because the numbers will simply be too high. So the hand of the government will be forced to take some drastic measures to get the numbers down. So if we are able to kind of level off at what we are at the moment, which is again the peak of the first and second wave, which was very high at the time already, and we open the schools, then we have to take some other measures to balance that opening. So you can't have both. You can't have just relaxation of measures and then just hope for the best. So anytime you open something, you have to compensate by doing something else. Right? So CO2 monitors might be part of this. And in fact, behind the scenes, we're also working on kind of build your own kit, build your own CO2 monitor. So we might do a webinar in the future on that one once you have all the parts together. So the question was, what will happen if the schools open, if we stay on that level? I don't think that they will be open until Christmas. So there will be necessary action taken way before that. And then will just be the same story as we had last time in around October.
I think that'll be quite an alarming thing for a lot of people to hear, because I think they're looking for schools to open. But like you said in your data presentation, if we let the case numbers keep getting higher, and if they increase tenfold, like you said they might by the end of August, then it takes a long time to come back down from that. So if you let them get really high, it takes longer to recover. But I think that'll be a worrying precipice, or a worrying vista you're giving people. Anthony, what would you think on this whole point of educational disruption in the year ahead, and what do you think?
I think it could be very substantial. We've seen already that many children have had a good deal of disruption to their education. So often what happens is the whole class have to isolate at home. Teachers now have to isolate so that the school can't provide services. Primary school years have had to close down. And I'm afraid that the government's plan seems to be to tough it out, but there's likely to be very substantial disruption to the education of children. And the people who will suffer most, as has been the case before, are children from poorer communities, children whose families have fewer resources, children whose families and parents find it harder to support homeschooling for their children, either because of their environment, because of their working hours, or for whatever reason. And this is a choice the government has made. It's not too late to do something now to bring down case numbers sharply. But if we don't do that quickly, I think we will be into Philip's scenario in September. And I absolutely hope this is wrong. I hope none of this happens, that we're all sitting around in September saying, what were all those people worried about? But I'm afraid that it might happen. And there's certainly fair evidence that it could happen. So I'm quite concerned, particularly about primary schools over September, October, November. I think we could be in for some very, very challenging times. And I don't think the Department of Education gets it. And certainly some of the language that some people in NPHET have used about schools is entirely unrealistic.
Thank you, Anthony. I noticed one of the attendees in Zoom has their hand raised. Is it possible for somebody to activate the microphone so they could ask their question? See if they're... Oh, they've actually lowered their hand. Maybe they changed their mind. Or is it because... Okay, that's okay then. So that's fine then. Maybe they changed their mind, or maybe they raised it by accident. That's no problem. Okay, so I think we've had a very important discussion today. So, in this week where we have happily seen the vaccination program extended to the 12 to 15-year-old, Karina Butler said, that this was done for the benefit of that age group. There's a benefit to society, but that isn't what's driving them. It was a benefit to that age group. And we know that some of those benefits are linked to the things we were talking about today. It's linked to avoiding infection, because a certain percentage, a lower percentage happily, will get seriously ill, but also avoiding long COVID. And additionally, helping to avoid the educational disruption, the prospect of educational disruption. But, we don't have vaccines ready for primary school age children yet. And we do need to think about how we protect them in other ways. So it's not just vaccines, it's vaccines plus. And we need to be thinking about clear guidelines for schools to make them safer, and a clean air guidelines. And I wish we could get the architects that Gabriel Scally was talking about back, and I wish they had built our schools so that they all had really well-designed structures with really good natural ventilation. But that's not going to happen in time for September. And I wish actually that this had been planned for much longer ago. I mean, we've known for a long time now that COVID is airborne and that aerosol transmission is very significant. And we've had a lot of time to prepare for this. It seems like we're doing all of these things in a rush. When the restaurants were talking about opening, they delayed by a week so they could have some kind of new rules. These things shouldn't be delayed by a week because you're thinking of the new rules on the hoof. We should be planning properly and in a careful way. And we have a few weeks now, something like 5 weeks before schools are going to be back. And we need clear ventilation guidelines. We need clear and that are acceptable CO2 limits in terms of what is going to be sufficiently ventilated. We need to know how to improve the ventilation. If it's not already good, we need good mask advice as well, proper high quality masks. It is possible to purchase the FFP2, so that's the same as N95 or KN95s, different nomenclature, but it's possible to purchase washable, reusable ones. It doesn't have to be a disposable one. And that could be something that could be bulk purchased, you would expect. And these things, there's time for these. And as Gabriel has said, the money you spent on these becomes actually a saving elsewhere. So it is irresponsible, and it's financial mismanagement as well as health mismanagement and negligence not to spend this money in the right places. We've been spending a lot of money in this country and in other European countries and other countries around the world over the last year and a half, but we haven't always been spending it in the right places. And this is an expensive business, but if we were spending our money in the right places, we would actually not be spending as much, and we would be enjoying a better quality of life and better health for our population. So our young people are the ones who are the last to receive our vaccines, and the youngest of all are not eligible for vaccines. So we're very lucky in this country we have such great access to vaccination. And we must remember that there are other countries where even they're most vulnerable, have not been vaccinated. And that's another point that has to be emphasized as well, that this should be opened up in terms of allowing other factories to manufacture these vaccines, so we can have not either or, but everybody getting access to vaccines. And that's an important point. But we have the tools at our disposal. Science has provided a huge amount of tools. It's provided the vaccines, it's provided information about the transmission mechanisms, about how to prevent the non-pharmaceutical interventions to prevent transmission. Now it's policy that's lacking, and we need that. We need the good policies for the safe return of schools and to protect our young people and children. So thank you all for listening, and see you next time.